All right, everybody. Welcome to my hotel room in Washington, D.C. I'd invite you in, but I don't know that that would be appropriate. But I am here live with Jordan Johnson and Eric Rubenstein. So the three Chuckleheads are back together. Want to welcome y'all that are tuning in from whether you're on LinkedIn, Facebook, or YouTube. If you're joining us after this live presentation, welcome one and all. Again, the circus is the same, only the clowns have changed.
I like it. It's good to see everybody. Glad everybody could be here. I know I feel like coming in later in the afternoon. It's almost like Chuckleheads after dark or something. You better watch out.
It very well could be. And here's the best part. We get to talk about, because it's after hours, whatever we want to talk about. And there's so much going on in the world of healthcare. And, again, breaking news, but I don't think it should be a big surprise to anybody. The public health emergency has now been extended another 90 days.
I know. And a bunch of us were talking about that. And I think it's funny. So many people stay on the edge of their seat. And they're like, I wonder if it's going to be extended. I tell people, listen, as long as this administration's in, it'll be extended until this administration's gone. I mean, I think that's the MO of where we are right now. So no surprise. It's definitely going to make it through 2021. But that being said, I also don't think the PHE is going to be able to be used as an excuse to stop models, audits, that kind of stuff that CMS or CMMI. I don't think they're going to let that be a factor in any of it.
I agree 100%. Eric, go ahead, please.
Yeah, that's not gonna. I mean, extending the PHE isn't gonna stop the audits, the investigations. Just today, there was a press release. I don't speak Spanish. It was in Spanish. U.S. Attorney's Office in Puerto Rico. They've been putting out a bunch of press releases lately. This one was actually, from what I could glean, it was about a meeting that went on with about 15 or 20 agencies that have a vested stake in what goes on in Puerto Rico with respect to COVID and the virus. That they're going to be doing some upticks of the work that they do on the island. For those that don't know it, the Office of Inspector General for HHS does have an office in Puerto Rico, and they cover Puerto Rico and the Virgin Islands. That office is, interestingly enough, part of Region 2 out of New York, where I worked. So I would go down there for operations and the like. It's a very different world down there, but the law enforcement community is about as thick as thieves. And so the thing that'll happen is they'll be, once they get going, they're really gonna uptick things. And I think they're going to be mirroring a lot of what the enforcement operations and activities are that are going on around the country with some of the COVID-19 operations. Obviously, the PRAC, the Pandemic Response Accountability Committee, is going to be part of helping the Puerto Rico U.S. Attorney's Office in spearheading a lot of those fraud, waste, abuse things. But the PHE isn't going to change what happens. I mean, enforcement is enforcement. The PHE is meant to allow for things like the 1135 waivers, which we talk about, and some of those other things that are out there.
I agree with you. And here's the thing, and this is what boggles my mind, because if this truly was a public health emergency, we wouldn't be aggravating the heck out of physicians and hospitals and health systems with now reinstatement of targeted probe and educate. We wouldn't be harassing them with civil investigative demands, with administrative subpoenas, with criminal subpoenas. Well, criminal subpoenas maybe, but the administrative stuff. And just today, right? We're in the middle of a public health emergency, but yet today, we got a phone call from an attorney that I work with very closely out of Illinois, who said to me, I need your help. I need your statistician team. I need your data science team. We have two urgent care centers that are being rung up by Cigna in the amount of $1 million each for COVID-related services during the PHE. Well, folks, we're still in a PHE.
Right.
Yeah, and I
Yeah.
wonder if some of the PHE overall is, and you wonder if some of these commercial payers are like, we're done. Like the feds can have theirs, but I wonder if some of these commercials are like, we're done. Any of the waivers that and that's been talked about, right? You have to watch those timelines. But if they're just going to back out and say, listen, we're not going to let this train keep going. But I think this segues into what Eric was talking about is, never miss the opportunity of to make a lot of money off of a good crisis. And unfortunately, this is what we're seeing with COVID now. So Eric, I'll kind of turn it over to you. And there's a lot to talk about on this scale right now.
By the way, is it just me, or does Jordan remind you of a modern Charlie Chaplin?
Hey, we're trying, man. I don't know.
I mean, he's missing the cane and
if I grow it out more and can get the unibrow, it'll be more of a Groucho Marx or something. I mean, it's
grow it out or stop trimming it. I mean, you never know. Yeah, So the thing about the COVID. So let's talk about COVID testing.
Yeah.
And so there's an importance of COVID testing, and depending upon who you talk to, does getting a test, like so recently, as you guys know, I love going to concerts, and recently I went to a concert that required a vaccination card, proof of vaccine, ID that proves that you're the person, or a negative COVID test within 72 hours. And of course, the first thing that comes to mind is, if I've got a negative COVID test within 72 hours, but I got COVID within 24 and 48, what's the point of it? So I'm not really sure about that. And for people who didn't even have a COVID test, they were actually doing COVID testing on site, which is sort of this interesting point. So you go to school, and you're a teacher, you're a student, you're not vaccinated. I have friends in New Jersey. New Jersey has not instituted a mandatory vaccination for law enforcement. I have a friend who's a police officer with New Jersey Transit Police. They don't have a vaccination requirement. He's not vaccinated for a bunch of reasons. He's planning on getting it. He and his wife have been trying to have a baby. They're telling them not to get vaccinated yet, whatever. So he's going to be put on a course of vaccination up to twice a week. So he shows up to work. He gets an order to go someplace, gets tested. Great. I appreciate that. Jordan and I were talking this morning. He was in the great city of New York, my hometown, and walking around, he's noticed that there were COVID testing centers, every other block. Come in, get tested. Have you been tested? Have you been tested? Have you been tested? So the problem you run into is part of the PHE has created this state waiver program where in the normal world, you need an order from a physician or a doctor, an ordering practitioner, to be able to get a diagnostic test. You can't just go to your local, laboratory and say, hey, stick me in the arm. I want to know what my cholesterol level is, right? You need to have an order from a doctor to get that paid by insurance. But because of the PHE and all of that, that doesn't happen. And then, so you really got, when it comes time to pay the bill, there's two courses of action. If you're insured, your insurance is supposed to pay for it as part of the PHE and COVID-19 coverage, 100%. You don't see a bill. I hate when they use the term free, because nothing is free. Someone's paying for it. It's like when you see the commercials on TV, it's little to no out-of-pocket costs, or it's free for you. It's never free. Someone is always paying for it by hook or by crook. But if you are uninsured or underinsured, then you get that HRSA piece, which is really like grant money, right? It's treated like grant money. Providers go submit a claim through the HRSA website or the portal, and the contractor for HRSA for doing this, United Healthcare, processes that claim. But if a person has insurance, it's not supposed to go through the HRSA portal process. But you go and you walk around the city of New York, and you're Jordan, who's there for a week and decides, hey, I'm going to dip in and get myself a COVID test, and just go get one. And maybe 3 days later, hey, I'm going to go in and dip in and get myself a COVID test. Or tomorrow, I'm going to go and dip in and get myself a COVID test. And the problem becomes that all of these pop-up clinics that are here are really, is there a cost benefit analysis that we're going to have to do at some point to say, was the frequent testing of patients that were not otherwise needed to be tested, like testing someone who's on a vacation in New York City, where the requirement is you have to be vaccinated to go to places or have a negative COVID test, but you're not getting that test for 2 or 3 days, right? So you're in New York for only a few days. What do you do? So the thing to me that's going to be interesting is, are we just essentially pissing away this money for no reason, or are we spending this money for something that's going to have probative value for the testing, part of it? And I don't know the answer to that. I just know that the system is so, they just shoved it out the door.
Right.
And where are we on, from a compliance perspective, right? As a lab, what do you have to prove? What do you have to document to be able to submit that claim? You have to document like almost nothing.
Well,
there were no guardrails, right? I mean, they just shoved it out there. And to Eric's point, guys, we don't have that here in Mississippi. And not only were there testing facilities and buildings, they had trailers, like enclosed trailers that you pull behind a truck, sitting on the sides of the roads, and you just could drop in, like Eric said. I mean, boom, and then out the door. So I think to that point, and Sean, I'll turn it over to you, but is when they see how much money is flooding to no benefit, you better believe they're going to be looking to take a bunch of this back.
Oh, absolutely. So I'm now on my third week of being on the road. I'm here in DC, as I said, but over the last 2 weeks, I was in Orlando, Salt Lake City, Phoenix, Big Sky, Montana, and Las Vegas. And in what I found to be interesting in all of those airports on the West Coast, now I've not done any East Coast except here coming out of Atlanta. Every one of them had a Rapid Express. I don't know if you guys have seen this company, but
they have a similar. Yeah, there's one either the same or similar in Orlando, LaGuardia, Newark.
Yeah, LaGuardia. That's where I flew. They had one.
Yep.
I mean, you should see the people lining up to go in there. But here's the question to your all's point. How many of these people had a COVID test 48 hours ago, 24 hours ago, 72 hours ago, and now they're just showing up at the airport, and the airport's like, oh, okay, you need a COVID card? Come on in. We'll give you a swab, and here's your COVID card. And, what's the medical necessity of these tests? Because I'm telling you, this is going to be the big question, is the medical necessity of rendering all of these COVID swabs and all of this different COVID testing.
And the argument will be, the argument's going to be the medical necessity is sort of inherent in the PHE. So we can, there'll be that argument, but the question really is, for me at least, from a fraud and a compliance perspective, are these technicians properly because these are people that are being paid to do the swab. Like, what are they being paid?
Right.
It could be, minimum wage or some other, a lot of this is staff augmentation because these labs are not equipped to staff in the number of states that they are. So from a training perspective, are the technicians properly trained to vet out and say, well, do you have insurance? And be able to say, well, if you have insurance, your insurance will pay for this. If not, you get the test. Is that even being done? And to what extent is it being done? And to what extent is HRSA being burdened with the financial strap of the test versus someone's commercial insurance or Medicaid or whatever?
That's a great question. But Eric, beyond that, how many of these tests are actually being performed correctly? Because I got to tell you, I've had, unfortunately, like Jordan, I've had a run of bad luck with having to be in the hospitals. And every time, I was put in there, somebody different was doing a swab. Or if I went to the, urgent care, prior to, some of them just kind of go around in here. The most brutal one that I had was my pre-surgery COVID screen, where the guy literally stuck that thing into my nose and left it there and did a countdown on his watch for like 30 seconds. And I remember saying to the guy, take this thing out of my nose right now. I mean, and he said, but this is the only way to do the swab the right way. So I wonder, just beyond the money, and the strain that it's going to put on the financial resources of the system, how many of these tests weren't even done correctly?
Well, and exactly. It's not like the CDC or HHS or somebody said, hey, here's a handbook. Anybody that's going to do a swab watches this video, gets some little something. You know what I mean? That didn't happen.
No.
Yeah, I mean, I remember the couple of times that I got tested, I did it through like a drive-through pharmacy situation, and they pass the kit to you through the window, and they walk you through the instructions, and the big piece of instruction they give you is there's a notch on the stem of the swab,
Yeah, push to
and you
that.
put your finger, you have to put your finger at the notch, and you got to insert and rotate around and then go backwards without moving your finger off that notch. But I had a house guest this weekend who's been tested a few times, and he said, the first time I got tested, I had to insert the equivalent of a broomstick up my nose, and then the next time I got tested, it was like like a tiny little Q-tip.
Yeah.
And I said, well, maybe the technology has changed, but I don't know if the technology has grown so ostensibly so that it was able to make that much of a difference. But I think the interesting thing is going to be at least from a data perspective, it's going to be who are the big labs that are doing the COVID testing. But you're going to be able to, the data is going to parse that out. But from a compliance and a fraud perspective, the question is going to be, who's to say that the stuff that they were doing, right, wrong, or indifferent, right? I mean, there's almost nothing that's required from a documentation perspective to do this. And the provider is essentially just checking an attestation box when they submit their claim saying, we attest that we don't believe the patient has other insurance. Well, there's if Sean Weiss shows up to my clinic and I say, hey, Sean, do you have insurance? And he says, no, I don't have any insurance. And you're covered by some, BUCA plan, a Blue Cross, a United, Cigna, Anthem, that's BUCA. But you don't tell you don't tell the lab that because you've gone and gotten tested 3 or 4 times and you're worried that your plan is going to find out, whatever it may be. You don't say anything. How does the processing of that claim through the HER support, how do they know that? How do they know that you're a BUCA covered patient?
They don't. And that's the big problem with all of this. But, I want to, because there's so much for us to talk about. And I got to be honest with you. I feel like the majority of people that I'm seeing their posts, everybody's just so sick of COVID right now. They're so sick of talking about it. I'm tired of the political aspect of it. I'm tired of people professing themselves to be experts in something that they're not, because it's a novel virus. We're still learning about it. The CDC has even come out and said, we still don't know. There's so much we still don't know.
Hey, the best comment I heard was when I was in New York at the conference last week, where you had to be vaccinated and have your card to get in. And we were having the dinner, the luncheon, and Scott Gottlieb was talking, and he said his words out of his mouth were, well, I sure hope this isn't a super spreader event.
I mean, yeah. So before I go to you, Eric, because I really want to talk about something that you and I have been harping on for a long time, right? The difference between telefraud and telehealth. Yes. And finally, my good friend Eric Rubenstein posted on LinkedIn not too long ago. They finally listened, and they're finally calling a spade, which is what it needed to be. But before we go into that conversation, Jordan, you were at an incredible event, super spreader or not. You were at an incredible event, and it's really what we've been talking about for years in oncology, which is the transition to value-based care. And oncology has really been the pioneer in this aspect. They took this on. I went to a value-based care meeting with the payers. I was asked to sit in as an administrator on behalf of large clinics. And this is going back to 2015 or 16 was when I was at that. And then I had been writing for that publication, VBC. But you just got to attend, and I'm very jealous. You got to attend an incredible event with people like Scott Gottlieb, Seema Verma, and so many others. So can you talk about this event, and let's really talk about what transpired at this event and why VBC is so critical? Because you and I had another incredible conversation with the rheumatology organizations that are looking to transition to VBC.
Yeah, I mean, the nuts and the bolts of this conference were let's put the people and the stakeholders together, which is for one of the largest spends service lines, which is oncology. And right now, everybody complains about 15, 17% of the GDP's healthcare. And we look at how much money is in pharma and drug and cost with how many drugs are north of $100,000. So we put the PBM, representatives, we had pharma representatives, we had the vendors, we had payers, we had the systems, so we had hospital. And what became really interesting, the biggest kind of factors and takeaways is everybody agrees that something needs to be done, but it's like this big intersection, four-way intersection where everybody's there and everybody's waiting to see who's going to make the move, who's going to give something up. You got one group that says we got to do away with buy and bill, and we got another group that says it's pharma's responsibility, they charge a lot for the drugs. But then you have these pioneers, and I'll use them: one oncology, Florida cancer specialist, I'm trying to think, it's Texas Oncology, that have really mastered the OCM, OCF. And I think what we really learned is these community oncology practices have done excellent. And they exploited their numbers, actually significantly went up during COVID. And it makes sense because people didn't want to go to the hospital. They wanted to go to community settings. And so they've already figured this out. They've leaned stuff out. They're actually performing well under value-based care models and making money. And I think it's the knee jerk now that the hospitals are going to have to, they're kind of called to the table in the forefront. A lot of talk, obviously, on site neutrality leading into that. But, price transparency, we talked about, that'll play a role. But one of the other takeaways was we're looking at basically 2.5 years left, and that's it, of what's left in the tank for Medicare. Something has to change. The drugs are going to continue to get expensive. How do we pay for that? Is it straight fee? The other thing is, the MPFS continues to get cut. So we give doctors more and more responsibility, MIPS, MACRA, PQRS, back in the day, all this other stuff they're having to do, these reporting mechanisms, we pay them less. And then, that's why we're seeing, I think they reported where 50.6% of physicians now are employed by the hospitals. Well, they don't necessarily want that, but they get stuck in that, that's where they're at. And so, that was the big takeaways. I think SEMA Verma definitely not being on the administration could be more vocal. But she called some things out that, I'll be honest with you, no political opinions here, but she definitely is headed in the right direction and was headed in the right direction and set the stage for some things. But she did absolutely say that CMMI will not back off. They're going to continue with these value-based, good, bad, or indifferent. They're going to push forward, and they have to look for something. So that was kind of the highlight of the conference.
Well, the well is running dry, right? I mean,
That's right.
Each year, Social Security, Medicare, they're both going south. They keep talking about Part B, as in boy, not running out of money because it's perpetually funded through premiums and the like. But the latest report with Social Security is going to be only at a 70%. You're only going to be able to get 70% of your check when it starts to go dry in a few years. Medicare is going to start to go dry. And the problem is that the can just keeps getting kicked. There's got to be something that's got to give in order to allow this to continue to go on.
But what's going to give?
One way or another.
The other thing is, why is Medicare Advantage, and this was what we all brought up, a bunch of people talked about this, but a lot of these models and stuff that they're coming out with, Medicare Advantage is exempt from reporting that's traditional Medicare only. And I get it because that's all they have their hands around. But one of the largest, fastest growing payers is Medicare Advantage. Why do they get a pass on all of this?
Well, I think we're starting to see that that's not always the case, right? We know that DOJ has a couple of lawsuits going on right now against some of the larger MA payers. And so, on the HCC scoring, those risk adjustment scores.
That's right.
Where I work at Advise, we've got a couple of plans that we do outsourced SIU work for. It's not the line of business I do. We have a guy that's oversees that, but he reached out to me the other day and said, hey, do we have any auditors that you use that are certified for HCC scoring? Because there are two small plans that are looking to redo all of their HCC scoring. I don't know about fraud, waste, or abuse. I just know that it's on the radar. People are looking at it. People are realizing that this is a money-making opportunity on the payer side, and the payers are going to have to do some things to right their own ship, and that's one of the ways that they're going to have to do that, right? I mean, it's just running out of money. I mean, at some point, you just have to stop. I think the alternative is that the government will continue to prop up the economy, and in one way. And so I have somebody who I talk to pretty often who is saying that what we're doing with our purchase of various commodities is the government is buying back a lot of its own stuff and is doing what Japan does. So Japan props up its economy by making purchases of its own debt. The US government is starting to do that also. And we already know where Japan's breaking point is because we saw where it broke, and we're not near that. So we'll keep doing that until we probably hit that. But that value-based care piece has got to be the thing that happens. People, you need to, the value-based care is more bang for the buck. That's really all it comes down to.
And I think they were proving some of that. And there's nasty arguments on it, but like things moving home. Home infusion can absolutely safely be done. Now, there's lots of reasons why a lot of med-oncs and different people don't want that done, right? They'd rather have it done in their office. But, Jefferson Hospital was there. They gave some examples of where they're sending nurses home and that patients enjoy having the infusions in their home rather than having to go to the hospital. And it's working. And it cuts a lot of the costs down. But that's a knee jerk. It's being covered by insurance companies. But again, there's a group of people that are fighting that. I think it's a pointless fight. I think that's going to happen. These home-based models, things like that. The traditional hospital as we know it, stick a fork in it, it's done. I mean, I think the way that's structured, it's been the same structure for 40 years. The way that's worked, you build the hospital, you expand it, everything. We want to keep you in the hospital. Now the goal is like, don't go to the hospital, right? And we're going to see that, 5 years, let's give a scratch, or 3 years, we'll give a scratch because all the delayed testing in oncology, we're going to see people are going to have to go. But I think long term, things are going to move out of that environment.
Well, wasn't that, Jordan, a little bit when I started the OIG in the mid 90s, the one thing that sort of became an explosive business model in hospitals were these innovative centers of blank, a joint center for knee and hip. And so that helped with value-based pricing, right? Because the hospital, if you put in a $10,000 triathlon striker knee, the hospital gets paid the same whether they put that $20,000 knee in or they put a $6,000 erector set in your knee. They're getting paid the same amount of money. And so the object became that the more of that procedure you did, you can then go back to that manufacturer and get sole source pricing. I mean, I had a case at the OIG when I was probably about halfway through my career where a hospital became a joint center. And the rule was that if you wanted to do knee surgeries in that hospital, you had to use a certain brand of knee. And what they did was they promised the manufacturer that 95% of the surgeries done were going to be with that particular manufacturer. And they actually got the same pricing this is a small community hospital in northern New Jersey. And they got the same pricing that Mass General got. And at the time, Mass General was at the time, like one of, if not the number one knee replacement hospital in the country. And this small community hospital had the same pricing as Mass General. And so, the object was we're going to try to keep the costs low, but also keep our profit margins high. And I just saw an article the other day that said oncology, knee replacement, and there's one other that I can't remember off the top of my head, are the big money makers.
It's got to be rheumatology.
Spine surgery.
Oh, spine?
And I think the other thing is who holds the vendors accountable. One of the biggest things that came up in conversations for a drug to move forward, the bar is set so high. It has to pass so many standards, efficacy tests, and all this. But for medical devices, like in radiation oncology and things like that, I mean, it's got to be FDA approved, but it's not a rigorous, what's the outcomes and value and all this stuff. And so it gets thrown out there and people buy it, and they know the hospitals are going to buy it. CTs, MRIs, the exact same thing. It didn't take much. They raised the price. So at what point do the vendors become accountable? And that was a big part of the talk too.
Well, that's where I think in the FDA said that's where those 510Ks are, right? The 510K, the substantially equivalent. I think I talked about it on this podcast. I know I've talked about it before about a case that I had involving a company called Otismed, and Otismed had developed a jig for knee replacement surgery, and they claimed that the device was better than there were other systems out there. One was a computerized navigational system, but this was an actual jig for the placement of the screws for the knee replacement. And there was no additional reimbursement that came out as a result. And so the way that they got hospitals to buy into it was in order to use this jig, you had to get an MRI, which an MRI is not normally part of what you would need to determine that you needed to have a knee replacement surgery. And so the sales pitch was, you need to get this, you get this MRI, because the MRI then goes to Otismed, and then they have algorithms to, make each one individual. And what happened was they filed their 510K. And when they filed their 510K, they said, this is no different than these electronic navigation systems that are out there. And well, lo and behold, the FDA came back and gave what's known as the NSE letters, not substantially equivalent.
Right.
This is not the same as the navigation system. You've got to get all your clinical research in and what have you. Well, when they got that letter, the CEO of Otismed is a guy. He's no longer the CEO, but it's a guy named Charlie Chi. And Charlie Chi essentially said, well, we've got a couple of $100,000 of product. We've got to get it out to our clients. And, we've still got to we're building this reputation. We're going to sell the company. And so essentially said, ship it. And so these devices were shipped, and people wound up having knee replacement surgery using a device that the FDA said, hey, this isn't substantially equivalent. At the end of the day, Otismed wound up being bought by a larger company. And then in due diligence, they wound up as a company pleading guilty criminally to this. And Charlie Chi wound up getting charged with the misdemeanor misbranding, which is interesting because misbranding, you could really have some very harmful potential effects for a patient. It's still only a misdemeanor. But Charlie Chi wound up pleading guilty to 3 misdemeanors and was one of the first corporate people in the country who had, been charged with the finger was pointed at him, and got 3 years in prison because he went through this. Hey, we have this device. And when the FDA came back and said, hey, sorry, Charlie.
Hey.
I see what you did.
See what I did there. I mean, it's a long story to get to that, but it's good.
You did.
But that becomes the issue in the device world, is that the amount, so what I don't know, and I don't know if you guys know it, Jordan, if you've ever seen this, but is the cost of getting a device to the market even close to the cost of getting a pharmaceutical on the market?
Oh, no, nowhere near.
Right.
I bet it's not even 10%.
I agree.
Probably less than that. And that's what they were talking about. The standard for a drug is so high, so much goes into it. And these medical devices, in essence, in comparison, it's very easy to get a medical device. Like you said, I mean, it's got to meet some criteria, but it's nowhere near the level of clinical trials and all the stuff that has to be done before it can get there.
Yeah, I mean, you got to have double-sided blind testing. You have to have all this stuff done in pharmaceuticals. And, I've done over the years, I've done a number of 510K submissions on behalf of organizations, and the requirements to submit to get approval, nowhere close to what you go through for the pharmaceuticals. Right. Nowhere close.
Right. I mean, there's so much that goes in. Interestingly enough, this weekend, I was out at a place and I ran into a guy who could be the Chucklehead of the week, but he was not a healthcare provider. And he started an argument with a friend of mine about the vaccines not being FDA approved. And I was like, well, hold on, they're all approved now. And he said, well, what are the ingredients? And I said, well, I'm damned if I know. And he said, well, don't you want to know what you put in your body? And I said to him, what's an aspirin? Do you know what the ingredients are of aspirin? And he said, no, but it's approved. And I just shook his hand and I said, have a good night, my friend. I mean, it was like a little white drop. Like, are you kidding me? Like, he was like, well, how do you know it's not toxic? I said, well, if you take too much aspirin, it's toxic. Let's have a nice night. See you.
Yeah, again, this is the thing that's driving me absolutely bonkers. And look, again, I'm tired of the whole COVID conversation. I've had several people, they're like, "Oh, you're an anti-vaxxer." I'm not a freaking anti-vaxxer, okay? I've got my card, but I also believe in the freedom of choice. I believe that people have a right to know, why are we doing this? When Finland and the Netherlands and other countries around the world are coming out and saying, hey, we're still in a public health emergency. We get it. It's still a pandemic, but we're at the backside of this thing now. And we can equate COVID to the equivalent of a bad cold, a flu. It's got a 99.9% survival rate. I'm tired of this whole debate about ivermectin. Stop calling it a horse dewormer. It is when it's not prescribed by a licensed physician, okay? Ivermectin has its benefits, maybe, maybe not. Who knows at this point right now? But here's what I'll say. I'm tired of the whole COVID conversation. If you want to have the vaccine, it's available. Get it. I mean, there was a debate today. We're talking about the fact that Colin Powell, may he rest in peace, wonderful, wonderful human being, was instrumental during the Bush administration, during 9/11. The guy was just an incredible career. If you don't know about this man, unbelievable. God rest his soul. He passed away today and this is from his family, complications of COVID-19, and he was fully vaccinated. Now, I know some people are going to come at me, as they did earlier today, and they're going to be like, wait a minute, Sean, this guy had this, he had this, he had this, he did that. His family released his cause of death, complications of COVID-19, fully vaccinated.
But did you hear the other half of that story is that he suffered from multiple myeloma.
Yes, he did.
Which they've said is an immune compromised cancer, and people who have it are more susceptible to virus. And so they're saying that part of the issue with Colin Powell having been vaccinated was that his immune level was already so compromised that getting the vaccine, did they ever check his antibody level? Did they know he was fully vaccinated? But how are his?
What about natural immunity? I mean, I get it. So there's so much unknown. Listen, folks, I love every single person that I come in contact with until they give me a reason not to. I want people to be healthy. I want people to live long, successful, healthy lives. Do what's right for you. Do what's right for your family, and leave it at that. You've seen a big change in this current administration on this push for the mandates. There are no mandates at this point because they've not been pushed through. The ETS, the emergency temporary standards, have not been pushed through, right? So, with OSHA is what I'm talking about. We have no mandates from them on any of this stuff yet. And I think you're going to start to see a narrative change coming down the pike. And again, this has nothing to do with Democrat, Republican. They have to change the messaging because it's been piss poor from the very beginning. Pardon my English. But I agree with Cairo Medicare. Medicare is a political promise that cannot be broken and a fiscal promise that cannot be kept. That's brilliantly said.
That's perfect.
It is well said. So
you know what I'm terrified? I'm terrified about when the public health emergency is over and COVID is sort of, becomes a thing that we don't talk about. What's going to happen to us? What will we be talking about? You know what we'll be talking about? We're going to continue to talk about telefraud.
Telefraud. So let's
that's what we're going to continue to talk about.
See, you did it again. You're getting good at this.
The host with the most. I know.
That's it, baby. So let's get into this because you and I have been absolutely going crazy over people calling this, telemedicine, healthcare fraud, and it's not. There's a difference between telemedicine fraud, which is the rendering of a medical service by a provider for whatever reason, it does not pass the scratch and sniff test. And as such, it becomes a potential false claim,
Right.
which means it's potentially fraud.
Right.
As opposed to telefraud, which is conducted by non-medical organizations where they are literally dialing for dollars. Eric, take it away,
Yeah.
brother.
Yeah. I mean, that is the truth. I mean, look, and you and I are currently working on 4 different projects, right? We have 4 different issues going on with compliance related issues that are telemedicine related. The OIG is strongly working on these. We know it. It's not a secret. We've got 4. Actually, I think we have 5. We have one that we've already dealt with, and there's 4 that we're currently working with. So we've got 5 provider groups that we are currently helping to navigate through, who are involved with, sort of the usurping of their NPI numbers. And you and I and Jordan, we talk about this, and I've been talking about tomorrow. I am on 10 Talk Tuesdays, the ICD-10 Monitor with Dr. Erica Reamer. I'm being interviewed by them as part of their podcast about the fact that this is just not the case. Calling it telemedicine is doing a great disservice to the provider community who do telemedicine and telehealth. This is telemarketing fraud or telefraud or whatever you want to call it. Last week, OIG put out on their LinkedIn site that they actually came up with an infographic of what they're calling telefraud versus telemedicine. Right. They've broken it up into bullet points, and I posted on LinkedIn. I think I was giddy with excitement because I was really excited about it. But the fact that the community as a whole, the country as a whole, there are TV commercials ad nauseum. There are radio advertisements. There's internet advertisements. And most of it is the stuff that ultimately leads to your information getting hijacked and some nefarious provider who's getting paid $20 or $25 to sell their soul at the risk of potential patient harm when you're talking about prescription drugs at the very least for a vulnerable population of people, the Medicare population, which is vulnerable. And it was the one thing that, in my career, if you were a provider who submitted a bogus claim, you did a kickback, you did your thing, the patient really needed the lab work, but you sent them to this crappy lab versus a better one, but the test was okay. I had a lot less of a thorn for that than I did for the telemarketing stuff, because that to me is, my grandmother is 90 years old and she's sitting in the nursing home and she's watching TV and she's getting a phone call from someone who says, I'm calling on behalf of your doctor. I want to confirm your address. He wants you to have this medicine. You go, oh, okay. And then that's it, man. You're on the hook. We saw this which started with diabetic testing supplies. Right. That was huge. And even today, CMS puts the onus on the Medicare beneficiary to reach out to their previous supplier to tell them, I no longer want supplies from you anymore. And really what happens is with these companies, it's a race to the finish line. Midnight, 1 second click, hit the send button for that 90-day supply or whatever it is. So I was super excited to see that this came out. The OIG is, as you guys know, Jordan, it from the data piece. Sean, we're seeing it because we're dealing with providers who are getting subpoenaed and their information is like, I don't even know who this, I don't know these patients aren't mine. I've never even heard of these patients. So, the OIG is essentially putting its finger in a dike that continues to leak. And so it really is up to people to be able to know, hey, I'm not listening to you on the phone. I think there's too many times that people call looking to elicit information from you. And people are often too willing to give it. Social engineering is a scourge. I mean, it's unbelievable how good people are at being able to do it.
That's right.
So I was really excited to see that the OIG put out this infographic. I'm hoping that it leads to a decline. I'm hoping at the very minimum, the stuff that we're currently helping get worked on is going to make some changes. And practices just need to be vigilant on these kinds of things.
Absolutely. Well said. Well, we're talking about fraud. So what about a segue into talking about some of the OIG work plan items? Because we're quickly approaching the end of the year. Obviously, OIG is not going to be able to investigate every single thing that they set their sights to each and every single year. So some of this stuff carries over. One of the ones that jumped out to me was the audit of Medicare Emergency Department Evaluation and Management Services. And I think this is critical because ER physicians have been under the microscope for years. I'm in the middle right now, literally the middle of a huge DOJ case against a group of emergency medicine physicians. And I will tell you, it all centers around evaluation and management services because there seems to just be this disconnect on the fact that just because somebody presents to the emergency room doesn't automatically make it a level 5. It doesn't automatically make it a level 4 because as you both know, Jordan as a former hospital administrator, Eric as an OIG special agent, looking at this stuff, we know that there are a lot of frequent flyers coming to the hospital. A lot of these folks, they go to the hospital because they know that they can't go to their primary care doctor. They can't go to an urgent care. They can't go to a cardiologist because they're too far in debt. They owe too much money. They can't get back in because they have these exorbitant bills. And these providers don't want to see them because they don't want to keep expending valuable financial and human resources on these individuals when they can't collect. So what happens? You have these patients with chronic diabetes, COPD, CHF, CAD, who are frequenting the emergency room. And these are people that have chronic conditions. And a big question is, well, what constitutes a chronic condition? Well, anything that's gone on longer than 6 months is by definition a chronic condition. That's literally how it's defined, both by the AMA and the Centers for Medicare and Medicaid Services.
Does being henpecked by your significant other for many years, and for you, it's been a very long time, does that mean that marriage for you is a chronic condition?
I am so happily married.
Yeah.
I gotta tell you.
I know.
No, I mean, listen, in all sincerity,
she hadn't killed him yet.
Well, listen, for you, travel so much, it's out of sight, out of mind. Absence makes the heart grow fonder, whatever your colloquial is. No, I'm sorry, I digress. But, I spent a lot of time, I worked my way through college and graduate schools, an EMT and a paramedic, and I was with emergency services in a number of major cities when I was, going through college and stuff. And we used to have, I worked for the municipal system in Buffalo, New York, where I went to college and graduate school. And in New York at the time, and I don't know if that's the case now, we're talking about the late 80s, early 90s, the rule was that Medicaid would reimburse for transportation, but it was only one way. Right? One way, right? So what would happen was people would call 911 to go to the hospital. And then they would get there and they would get their voucher to be able to get home because they only get there one way. But we would have those frequent flyers. We would call them Gomers, get out of my emergency room, because those are people that were, routinely coming in and out for what would just be considered otherwise services that would be rendered in a place other than an emergency room. Like you would go to a clinic or something like that. So I think, where you're getting, Sean, on this is exactly right. Like these people are going in and, the emergency departments are, the one issue I've seen for sure, because we've done work in this, is a non-matched claim, meaning the ED group is billing a level 5 and the hospital is billing a level 4. And so right there is going to immediately create a flag. And like, how do you fight? If you're a provider in the emergency department, how do you fight that? If you're the hospital, how do you fight that? I mean, Jordan, as a data guy, how is that not getting spit out? And how isn't somebody saying like, hey, this is like, how is it that the hospital isn't talking to the ED group and saying, hey, we should at least have our ducks in a row so that if we're both going to get shit on, we at least have an equal argument on who's getting how much poop we're getting thrown at us.
Well, and I think somebody would have that data, right? I mean, I feel like somebody, if you're the hospital, coding what's going out and all that stuff, you've got a report, right? So how come they're not talking? By physician, we can see what's being done. Obviously, if they're employed, if they're not, the physician should at least be reporting some of that. So I mean, I'm like you. I don't know. I mean, that's like the basics of communication in these reports. I don't know why it's not being done.
Well, here's what I want to talk about, right? And Eric, I want to come back to you on some of this stuff as well. So when we talk about, I just want to kind of finish this thought, right? So when we're talking about the audit of Medicare Emergency Department Evaluation and Management Services, what they said is this, quote unquote, all E&M services reported to Medicare must be adequately documented so that medical necessity is clearly evident. This review will determine whether Medicare payments to providers for ED services for emergency department E&M services were appropriate, medically necessary, and paid in accordance with Medicare requirements. Now, let me read this to you real quick, okay? Because this is dealing with medical necessity and the False Claims Act. So here becomes the question. If an ER physician knowingly is submitting bills that are above the rate that they should be billed, is it a violation of the FCA, right? Because it says knowingly the submission of false claims for the purpose of receiving an entitlement for non-covered services. But then you also have to take into account reverse false claims, which is knowing an improper avoidance of an obligation to pay monies back to the government. So if you get paid for providing these services at a level above what you should be paid, and then you fail to refund that money under ACA and the 60-day rule, I mean, are we now entering into the realm of the False Claims Act?
Well, that's a good point. I mean, the issue is you knowingly submitted a claim for a service that was not medically necessary based upon the documentation. So it should have been a level 3. You submitted it as a level 4. I think the problem is that if you don't go in and refund that money, then you're causing that claim. There's an intent issue that comes in there, right? The level 4s and the level 5s, when you read those with respect to emergency department services, that's like life or death. Like my favorite is, my friends who will say something about, I got this claim, my doctor's office got paid for, and I go, well, what is it? It says level 5. And I said, well, level 5 is like 75 minutes with your doctor. Like, I don't know if I was on my deathbed, if my doctor would spend 75 minutes with me. So in the office, like that's just never happening, right? Like it's never happening. In the emergency department, level 4s and level 5 should be pretty rare. It shouldn't be the standard. I mean, a level 4 or level 5 is like a life or death situation or a near life or death situation. So if you're routinely coding a level 4 or a level 5, you're at some point, it goes from an error, a mistake to intent. Like at what point is a level 4 as a routine operational part of your practice, not really a routine operational part of your practice?
But so think about this, and I know we have some attorneys that are listening to us tonight because I've seen Matt Lawhon on here and I've seen some others. So let me ask this question, right? So now we're talking about the medical necessity aspect. We're talking about whether or not the service supports that 4 or 5. But here's the problem that I start to run into with the Medicare audits or the audits that are conducted by these contracted bounty hunters on behalf of the payers. The first section of the Medicare statute is the prohibition. And in the prohibition, it specifically says, nothing in this title shall be construed to authorize any federal officer or employee to exercise any supervision or control over the practice of medicine or the manner in which medical services are provided, right? So think about this. From this, you should be able to conclude that the beneficiary's physician should decide what services are medically necessary for the beneficiary. And also remember that there's a substantial line of authority in the Social Security disability benefits area, which holds that the treating physician's opinion is entitled to special weight. Now, I know people are going to say, but wait a minute, Sean, they threw out the treating physician rule from the Social Security disability benefits, a couple of years ago. And you're right, but they have not thrown it out in Medicare cases, because some courts have actually applied the rationale of the treating physician rule in these Medicare cases and have actually rejected various secretaries of Health and Human Services assertions that the treating physician rule should not be applied to the Medicare determinations. And if I'm not mistaken, and I'm sure somebody can fact check me, there was a case, it's Holland versus Sullivan, or Holland v. Sullivan. And basically in this case, the court concluded that though the considerations bearing on the weight to be accorded a treating physician's opinion are not necessarily identical in the disability and the Medicare context, the court said, we would expect the secretary, meaning the Secretary of Health and Human Services, to place significant reliance on the informed opinion of a treating physician, and either to apply the treating physician rule with its component of some extra weight to be accorded that opinion. But here's the crazy part. Even if it's contradicted by substantial evidence, and against that, it's to be able to supply a reasoned basis in conformity with statutory purposes for declining to do so. So I threw out a whole bunch of crap, right? But the reason why I throw it out is because we have providers that are going to be caught between a rock and a hard place, where the OIG who contracts with these auditing agencies is going to look at it, and they're going to come back and say, it wasn't medically necessary to bill a level 4 or level 5. Or these clinicians, and if we're talking about the prohibition of Medicare, no federal agent or employee of the government has a right to practice medicine. This is the sticky part. And this is why I've always argued the prohibition. So what I see you pulling something up. What do you have there?
So this is it. This is the case you're talking about. And it's a HCFA case. So it's all the way back to HCFA 1993, it looks like. Yep. It is HCFA's ruling that no presumptive weight should be assigned to the treating physician's medical opinion in determining the medical necessity of inpatient hospital or SNF services. A physician's opinion will be evaluated in the context of the evidence in the complete administrative record. Even though physician certification is required for payment, coverage decisions are not made solely on this certification. They are made based on objective medical information about the patient's condition and the services received. This information is available from the claims form and, when necessary, the medical record, which includes the physician's certification. So, yeah, I mean, I think, the issue with these is always going to be that when a provider is saying this is a level 4 or a level 5, and my record is going to prove it, that's really where the rubber meets the road. I'm dealing with this sort of the same issue. I have a provider who is insisting that his pulmonary function test is medically necessary and his documentation proves it. And when he turns his medical documentation in, it's just a bunch of numbers on a piece of paper. And we go, well, where is the documentation to support that this person? He says, well, it says that their tidal volume is 70. Okay, but where's, and so I think, that's where the rubber meets the road. And I think the issue is always going to be that, we talk about Jordan's stuff. The data is going to make you an outlier.
That's right.
And then you're going to come in and you're going to say, well, let's look at your documentation. Let's make sure your documentation passes muster. And then, you're going to look at it, and then I'm going to look at it, and we're going to say, hold on, it's 360 degrees. You may say, I'm documenting to the treatment of the patient, but the question really becomes, are you coding to the documentation for that treatment? That's really where and I say this all the time to our clients, it's 360 degrees. You can tell me until you die of, yelling at me that you are in fact documenting to the treatment. I believe you 100%. Unless you are Dr. Fata in Detroit, where it didn't matter.
That's right.
If you are documenting to the appropriate treatment that you're giving, that's phenomenal. But at the end of the day, all an insurance company cares about is, does that documentation match the code that you're providing? And if it is not, that's where that rubber meets the road. So all these docs that are talking about, these level 4 and level 5s on these ER visits, where in the medical record does it say that this patient is on their deathbed? And that's where the problem is going to be. The other problem, at least in the ED world, is that you've got a lot of these ED docs are, these are for profit, right? And they're getting a base salary, plus they're getting volume, because ER is a volume business. And then you just start to muddy up the waters, unfortunately, where that line could be drawn.
Let me read one last thing for you, because I found this to be really interesting. And we're talking about medical necessity, which means we're talking about risk, right? So the American Medical Association created a definition of risk when clinical and non-clinical review is being deployed by a payer. And here's what it says, quote, definitions of risk are based upon the usual behavior and thought processes of a physician. So Eric, spot on to your point, or other qualified healthcare professionals in the same specialty, which is why us as strategic litigation defense people, this is why we request the credentials for the physician reviewer in any case that we're arguing. And it goes on to say, for the purposes of medical decision-making, level of risk is based upon consequences of the problem or problems addressed at the encounter when appropriately treated. Risk also includes medical decision-making related to the need to initiate or forego further testing, treatment, and or hospitalization. So I think, there you start to look at that, and I mean, you further muddy the waters on how do you support these arguments? That's the interesting thing. So
exactly.
Yeah. So there's a lot of really interesting stuff on the recent work plan. If y'all get a chance to take a look at this, you can go to www.oig.hhs.gov/work plan. And there is just an incredible amount of information on there. And it's definitely worth taking a look. All right. So I think I got out everything that I've been holding in for like 2 weeks. And here's the good news. I'm back finally in my office next week. I know you guys are back in your office, and I think we can again start to be maybe it is Chuckleheads After Dark, because Eric, you are
clearly
dark.
I started out, it was plenty light, but I didn't want to get up and flip a light on and ruin the bingo. So I'm just, I feel like I'm like a floating, it's Halloween season, so I'm like a floating head.
It is. It's pretty cool. I like it.
And Jordan, I'm missing you in the hat, brother. The one that your dog ate half of.
I know, man. He finished off the rest of it. So wait on the next one.
So for those of you that don't know, Eric Rubenstein is a major KISS Army member. This guy has traveled around the country. He's been to Washington State. He saw him in Tampa. He's going to see him in Las Vegas for New Year's Eve. He's going to see David Lee Roth the day after. This guy is major KISS. Real quick, in wrapping this thing up, what was the coolest part about seeing KISS on the End of the World tour?
So the coolest part of the tour is the fact that everybody in the crowd is entirely into the show. So everybody knows the songs. I've seen them so many times. I know the set list, so I know what's coming, and it's phenomenal. Gene Simmons still does the fire. He still does the blood. He's 72 years old, 40 pounds of gear. Paul Stanley comes out into the crowd about halfway through, does a couple of songs. It's amazing. You know, Gene Simmons, 72 years old. The kid in the group is Tommy Thayer, who I think is 60 or 59.
60. Yep.
Paul Stanley is 70. Eric Singer, who's actually a very underrated but amazing drummer, is 63 years old. I love him. It's a great show. I was really excited about seeing them in Tampa. I'm super excited to see them New Year's Eve in Las Vegas. They're going to be playing in a 7,000 seat arena. I've got great seats for seeing that. I'm sure they'll do the same set that they do. It's very formulaic, but it's catchy. People like it. It was just cool to see them for what is going to be one of the last times in a big arena type situation.
Well, I can't wait to get my T-shirt, man. I'm excited.
It was dropped in the mail tonight.
I like it.
I can't wait. Jordan, what else you got going on, my friend?
Man, that's it. I mean, right now it's processing, getting ready for the final rule. Next month we come out. So I think getting ready to see what practice impacts are going to look like. And then, here locally, it's mowing season's almost over. The temperature's breaking cold. So hopefully no more mowing.
I know you and me, we're going to be putting those tractors up here in the next couple of weeks.
There it is, man.
And I got to tell you, that's one of my favorite things is getting on that tractor and bush hogging for hours. And it's just completely mine. Look at Eric.
Listen, Eric, I got to hang out with those New York rats at 5:30 in the morning.
You got to saddle them bitches. Saddle them
Right.
All right. On that note, I'm going to say, guys, it is so good to see you. I can't wait till we get a chance to get together again next week to do another live segment of Coffee Compliance and Chuckleheads. Folks, thank you to each and every single one of you that is tuned in live, both on all three, LinkedIn Live, Facebook, and YouTube. We greatly appreciate all of your support. Again, we want to say thank you to Invader Coffee. We want to say thank you to each and every single one of you who have stuck around with us so late into the evening. Again, on behalf of myself, Sean Weiss, Jordan Johnson, the man, Eric Rubenstein, thank you. And until next time, be good to yourself, but most importantly, be good to each other. Take care.